All this is Dr. Mobeen Sayed from DrBeen.com. Welcome to one more show. With me today, we have Paul Bork, our own Paul Bork, and you have heard many of his discussions in the past. I am wearing these headphones just to see if the echo can be cancelled and not occur. So just don't mind that. Paul, welcome and take it away.
Thank you very much, Mobeen. So we have a number of things to talk about today, and was able to catch up on the mortality question that someone asked yesterday. So we'll just go forward. Going to start with something a little different. You may have seen that CureVac has now sued BioNTech in Germany. They're both German companies, and they are alleging the development and sale of the commentary, they're not alleging the vaccine that was used under the emergency use authorization. And if it's in a suit in Germany, it's only focusing on the German infringement that occurred there. There may be suits around the world, but this is just about in Germany. And they have not sued Pfizer or Moderna, but expressly said they hadn't ruled it out. They cited 4 patents that they said were being violated. And the details of the mRNA, messenger RNA technology to make the Pfizer vaccine violated multiple inventions, including stabilization of protein inventions, they're saying. And they said they are not, they're seeking just fair compensation. They're not seeking to shut down the vaccine at all. And they said it would not have occurred to them to sue during the height of the pandemic, but now that things are under control, it's time to get the money. And they did not mention the Moderna suit, and they did not mention any suits outside of Germany in there. And BioNTech said they would vigorously defend it. And they note that there were prior suits from a Massachusetts company that brought suits against Pfizer and Moderna, and one of them settled, and the other one is still pending. And CureVac has its own vaccine, which it started a clinical trial. It's their second generation in partnership with the British GlaxoSmithKline. The first generation vaccine only generated a 47% efficacy, and they dropped it. It was a financial disaster. They said with sobering results when they were talking about the impact of that. And now they have their next one that's sort of ready to go, and they're taking a look at trying to go forward. And the discussion at the time wasn't sure why it had failed, because they're all supposedly pretty close. But CureVac did not alter the natural spike protein of the in their mRNA vaccine. And Pfizer and Moderna did modify it to prolong life, and so as to not trigger the interferon production. And so again, that could be a difference. And also they had a much lower dose, 12 micrograms versus 30 and 100 for the other two. And perhaps they reduced it to reduce the side effects with the triggering the interferon generation in the cells. But anyway, last year, CureVac lost 412 million euros, and BioNTech sold 19 billion euros of the vaccine and expects 17 billion this year. So CureVac is trying to see if they can get a transfer of money, sort of, like transfer blood from one organization to another. Well, they're trying to see if they can get some of the money to come over, I think.
And I think we're going to observe these kind of things now as the pandemic is kind of winding up. I think there's going to be this kind of settlements now to see what is fair and not.
Right. And these lawsuits, there's a phenomenal amount of money at stake. If the German is like the U.S., they typically treble the damages. And so if it's found infringing, you've got, here in these 2 years, you've got, $36 billion. And if you treble it, that's an awful lot of money that is potentially at risk. And this is worldwide sales. The suit's just in Germany, but there's always a lot of money. And if they go to trial, it takes a long, long time because they try very hard to get every advantage they can. And it
Got it.
says that their second generation vaccine has a 10-fold higher neutralizing antibody concentration. I assume that's 10 times higher than their first generation. And maybe they changed the adjuvant or concentration or the spike protein or whatever. I don't know. But anyway, they have another vaccine that's about to come out. Maybe it has better results against the later variants, and maybe not. But anyway, it was in the news. I thought I would just cover that. Any questions or concerns about that?
I think no.
Okay. So let's go to the variants and the CDC and their nowcast or forecasts that are forecast from up to today. So we have a couple weeks where we can see here, this is, and I put this yellow box to, they have a little brown box at the top that says it's a nowcast. I put a yellow box just to help differentiate those that are forecasts and from those that are data. So to help look at these, all these lines that are the same color are the same length. Okay, so we took a look at what it was on 5/14, and this was the BA.2.12. And if we go to the let's see, wait a second. So we take the 14th here, and we take a look at where it was in their projection for the 4th, and you can see it's about this far. And if we go to the 4th here, we can see that the BA.2.12 is less than what was estimated. And if we go down to the yellow and the BA.5, this was what they were projecting for the 4th. We take a look at the 4th, they're about 10, 20% off. And then if we look at the 11th to the 11th, again, they are low in what they're estimating for it. And the BA.4, from the 4th to the 4th, the blue, it looks like they got it pretty good. And if you go this one, see the extra space. The BA.4, they're estimating about right. But the BA.5, they're underestimating about 10 to 20%.
Got it. So the question that I have, is this still the forecast, meaning BA.4 plus 5 together, are they almost dominant or 50%, or that is still just a projection?
That's a projection. Everything with the box around it. So 611, I think, is the. They came up with another one. If we go to the next slide, they've got they're projecting out here, and these are projections, and their numbers are just up to 618. So they're a couple weeks behind, and they're doing this. This was a 611, so they have a 618 is the best, is the latest data they have. So this is the data they have, and as you can see, BA.4 and 5 are not 50% of the new cases. The 50% number that you keep hearing about, or 70%, is their forecast. And they have been low on the BA.5, but they don't have any data to support it. This is just their estimating about the future. And you can see even in the latest one they still have a little black line. So they're still saying there's some new BA.1 cases coming in, okay? And these are the BA.2 cases. And these are the BA.2.12. And so all these together, even in their forecast, are still 30, 35% of the new cases. And so if you take a look at the existing cases, we still have an awful lot of disease in this country that's not BA.4 or BA.5. Now, and so they're still underestimating. I don't understand why they haven't updated their estimation technique, if by nothing else, just to increase it by 20%. Because you've been wrong 3 weeks in a row. Why would you not just, or make half the difference, do something? But apparently they're sticking by the way what they're doing. And then one of the questions is the cases in the U.S. are supposedly not increasing, but if they really are increasing, perhaps the BA.2.12.1 is continuing the way it's going, and we're just getting the bigger denominator, so the percentage of the cases are going down. And so I don't know. And so the question is, if BA.2.12.1 and BA.4 and BA.5 are head to head, which one is going to do better? I don't know that we have the data from the US. And it may well be, if the number of cases aren't going up, that these two are increasing, the BA.2.12.1 is decreasing. But it could also be that the BA.2.12.1, perhaps the reinfection rate is lower than the first infection rate, and perhaps it's just ending its pandemic, and we're having the BA.4/5 coming in as a new infection going forward. So again, I don't know that the data that the CDC is sharing allows us to figure out which of those is taking place. And it's very likely that that it's just the same thing as before. We have a new variant and the old variant's going away, but it doesn't look the same way as the other curves did when they went away. You know, as you can see how these all step down or whatever, and the BA.2.12.1 doesn't seem to be decreasing the same way. And maybe it's just the BA.2 is doing something, but again, if it was just going forward the same way as before, we would see the same thing, and we're not seeing the same thing. So, I mean,
Correct. And
I don't have answers. I just have questions. It doesn't look right.
correct. And the thing is this: if it was as they're saying, BA.5 is more severe and so on. If these were more infectious, of course, if they're becoming dominant, they are going to be more transmissible. However, the slower progression makes me think that even if it has an advantage, BA.5 and 4, that advantage is not too huge compared to BA.2.12.1. And so having those alarm bells going off that, hey, we are in trouble, I don't think these are justified, but I want to hear more from your stats.
Right. And I agree with you. I don't think that it's a crisis. And here I have a slide just talking about the pathogenicity of BA.4 and 5. And apparently the 4 and 5, the initial variant had identical spike proteins, which were different than the other ones. And so if we take a look, again, a little different analysis than you did yesterday, but it's same sort of result. If we look at Portugal and just take the peak incident rate to death rate, and the death rates occurred later, and we can just do it for Portugal and South Africa because I'm not aware of another country that's gone through the BA.4 and 5 as a distinct way. And Portugal would say that the incident rate was about half for the BA.4/5 versus the first Omicron, and the deaths were a little less. And so the ratio of reported cases to reported deaths is up about twofold. And we do the same thing with South Africa, it's down about a half. And so this is probably in the space of noise, saying that they're about the same. One is a little higher, one is a little lower. It's not a factor of 10, it's not a factor of 20 or 100. It's in the mode of rate where you would expect normal variation to occur. If you ran an experiment 50 times, you would expect, and they were identical, you'd expect some numbers to be high and some numbers to be low. And so I look at this, it seems like they're about the same.
And I have a question here. So these numbers, the case numbers, are these more reliable in Portugal and South Africa, or they are similarly fuzzy as is happening in other countries?
I don't know, but it doesn't really matter. The important part is if they report them consistently from the first Omicron wave to the BA.4/5 wave. Because even if both of them are half or both of them are twice as much, as long as it's just looking at the ratio of one to the other. And so I don't know if the numbers in Portugal and South Africa have changed or they're consistent between the two. But, you know, just like the joke about the guy looking for his keys where the light is, these are the only two things that I know we can look at. It may not be very good, but looking at these two doesn't cause me to be concerned that the BA.4 and 5 is either much more pathogenic or much less pathogenic. It looks like it's fairly consistent.
And just for those audience who have not watched the last two videos that I did, the rumor or the news of pathogenicity being more is an in vitro study from Japan where they pick the lower respiratory tract cells and try to infect them with the BA.4 and 5. And that was not in the in vivo environment. So there are no immune cells around, there is no lymph flow around, there is no blood flow around. So there's no appropriate body to actually see the full dynamics. So it shows more infectivity, but that doesn't prove it is really more severe. More severe, we are lucky that we have data from South Africa and Portugal to look at, and that can give us a lot of information. So back to you, Paul. Thank you for sharing it.
Oh, you're very welcome. And so the last question I have here is, could this be a vaccine versus infection result? Is it a difference because of the age? Is just natural variation? The fact that the cases are later, would Portugal do their vaccination and the vaccine has waned some? Is that part of it or some of it? And so again, with all these different factors, you know, I would not share the, you know, I share Dr. Mobine's concern or thoughts, and that the experiment that was done might be an accurate experiment, but it doesn't really tell us what's going on in people or populations. And if we take a look at what the CDC is reporting for the US, and remember that this is the historical, so if we go back up, this is historical, and so these numbers are during this nowcast, but they don't really know what the concentration or the ratio of the variants are. They just have their estimates. But they're saying that the cases are up just a little bit, fairly level. The deaths are down. And it may be that it's too soon if this is the BA.4/5 coming up to see it in the deaths. But the hospitalizations are going up a bit too. And so again, it's consistent with the cases being about the same as before. When the caseload comes down, the hospitals go down, and then the deaths follow later on. So, but this is what the CDC is reporting about the current trend. And that's all I have on the BA.4/5 and the current trends that we have in the US.
So if you don't mind, if I can just add one statement here, which I have been discussing before as well. Look, with the BA.5, there are two types of studies that are out there, in vitro mostly. One studies, for example, from Harvard, that says the immunity generated by vaccines or previous infections is gone. BA.5 and 4 have escaped. On the other hand, we are also seeing studies from Japan, again, in vitro studies saying BA.5 is more severe. So if you put them together, it actually doesn't make sense. One or the other has to be canceled. For example, imagine if you say that Harvard study is correct and Japanese study is correct. That will mean BA.4 and 5 will infect everyone, which we are saying it can. However, that would also mean they can severely infect people, or the intensity would be more severe compared to BA.2, which we are seeing now. So that means hospitalizations and deaths should be really high. Considering there is no protection, it should even be higher than even beginning of Omicron. It should look like Delta. And we are not seeing that. So then the only answer would be, if I use these studies to say, fine, there is no protection, but the data doesn't show any harm, either any huge harm or more harm than original Omicron. That means then the BA.4 and 5 are actually not severe. So there is, if you trust them, then there is a conflict that has to be resolved with science, and science cannot resolve it until we agree that BA.4 and 5 are milder and there is still protection available.
Very good.
Back to you.
If we go to the next strain, this is from the last presentation that I did. If you remember, had the idea that all these slopes of these colored lines are the same, and we're taking a look at the initial. Then this is the I don't know, I don't remember which one this is. The next one, the delta, I think, and then the alpha, and then this was the delta, and then we had the Omicron, and BA.1, the BA.2, and the 2.12. I don't think we've gotten the 4 and 5 in. That's what I said before, and looked like the slopes were all staying the same. If we go to what it is right now, it's expanded scale because they've changed the way that it's doing. And I got again the graph here from the first one, and it looks like these slopes are all the same. And so we're getting about 20 substitutions per year. It doesn't look like the variants are changing more rapidly than they ever had before. And it appears that each of the groups, there's this phase shift. So it's like a punctured equilibrium kind of thing, that a new variant comes from something that is either has more variation or less variation, because it went up here, it came down, and then it went up, and then it went up, and then it looks like it came down a little bit here. So it looks like the substitutions are showing that it is a consistent disease, a consistent virus, but it just is having the different variants that have different effect on people. And the rate here that they estimate is higher because it's not taking into account this phase shift that I'm talking about.
Got it. And Paul, can I quickly respond to one comment, which is actually a very interesting comment? The comment is, let's see, so why don't you think about the answer to Rima's question, how could we have no protection? I'll ask you that in a second. Although I am the one who said that. Blob Monster says vaccines don't work at all with 4 and 5. Okay, so let's take that as a face value to say, yeah, vaccines don't work. I would also say then the previous infections protection also doesn't work. If that is the case, and if you look at South Africa and Portugal's numbers, then you must admit that even without the protection, BA.4 and 5 are milder than Delta-like things. So congratulations, we have a more friendly virus now. So this is the dichotomy that I am identifying.
Right. The other thing is that, we had the influenza in 1917 that was a huge shift, and we had an awful lot of problems with it. But with the coronavirus, we have all the human coronaviruses that you've talked about. And when we talk about the vaccine and the protection, we're comparing it to a population that hasn't gotten a vaccine. We're not comparing it against someone where it is totally new. We said it was a novel coronavirus, but it may be that 60, 70% of our immune response was already learned from other coronaviruses. Whatever that was, that's the baseline that's going to be consistent in the test group and the control group, and you'll never find that.
Absolutely. And once again, now I'm going to include Rima's comment here as well. How could we have no protection? The thing is this, if today, I'm going to repeat now, if today we agree there is no protection from 4 and 5, the vaccines generated immunity or infection generated immunity, there is just no protection. If that is the case, then you have to also agree. If we agree on that, then we also have to agree, looking at the data, that the BA.4 and 5 are not severe, because the data does not show any more severity than BA.2 or BA.1. And if this lack of severity, more severity, is in the absence of any protection, then we are even better coordinated with this virus. The virus is even more friendly to us than previous ones. So anyways, I think we have protection. These are interesting in vitro studies. They give us good direction, but there is protection.
Right. And the study may show that there is no protection, and it may be a valid study. But if both the placebo or both the control and the test group have an underlying protection, you're never going to measure it. And so, again, if we're 90%, 87% of the way towards what a total vaccine protection would be, and then we just lose what the new vaccine gave us, or the additional infection gave us, over the underlying resistance that humanity has, as you said, we've got a virus that is very human friendly. And whether that's friendly because of what our immune system is doing or it's friendly just inherently, it really doesn't make a difference.
And I wanted to address one more thing. Some people said that when I am saying this message yesterday and now, it is somehow implying that vaccine should be taken. I have always maintained vaccine taking or not taking is your decision. You take it, good for you. You don't take it, good for you. You decide. I am no one. However, this is not pushing the vaccine. And this is also not a proof that the vaccinated are becoming more severely ill compared to non vaccinated. That's also a very absurd statement. So, the way to look at that is the following. Imagine you are in a society in the beginning of the pandemic when there was no vaccine. At that time, you could say 100% of the people getting infected are unvaccinated. Now, imagine you reach a point, be in the time where everyone becomes vaccinated. Then you are seeing that the reinfections are occurring. Then we would say 100% of the vaccinated are getting infected. Both statements in their own time frame may be correct because of the cohort size, but not because the virus has just decided to first infect the unvaccinated and then only infect the vaccinated. It is still our immune system and the virus, our status of our body's health, our immune system's responses, the balance of those, genetics. There are so many factors that account in to seeing who would respond in what way. Okay, back to you.
Thank you. And I was just thinking about this. There's a limit on how fast a virus can replicate, because most of the viral replication is using the human cell process. And so by definition, a new variant doesn't change the body it's infecting. And so those processes that take place at whatever speed they take place. And, like the the building of the proteins and from the messenger RNA and all that, the rate at which it's adding as long as you're using the body system, it can't really do that. And so there's a few things that it can speed up. And perhaps now what we're really dealing with is more of an immune escape advantage and not a speed advantage. And so we may not see as much of a change in the rate of the infection or the disease progression. And for example, I don't know that there's anything, but it may be due to something other than different amino acids in the protein change. For example, if there's a conformal change where the protein folds differently, and suddenly part of the amino acid is no longer accessible to antibodies, and it may be that it's a bimodal or multi, that the spike protein changes back and forth, and like a dog shaking water off, something like that, where it isn't really that it's inherently better, it's just that the immune system isn't working as well, so it can reinfect people that the older variant can't. So again, it just seems like we were hearing faster and faster was the thing that was going on with all the new variants, and now that doesn't seem to be happening. And so just some musing that I had about what might that be.
And Paul, can I quickly answer a question?
Sure.
Joel is saying deaths lag, hospital lag infection. Yes. Has enough time passed with BA.4/5 to say mild or not? Yes. So BA.4/5 were in South Africa, BA.4 in January and 5 in February, and dominant in, I believe, May. Then similarly, BA.4 and 5 have become dominant in UK. They became variants of concern again in May, and now they're dominant as well. So yes, not in the US, but in the other countries, the enough time has passed to be able to review their numbers. Now, one can argue that those numbers are not applicable to US, and I totally agree. In the US, regardless of how our healthcare authorities have been doing, thinking that they are offering the best ways of handling the pandemic, to the point of today's news, which has really made me quite upset, that Pfizer's Paxlovid has been allowed to be prescribed by pharmacies. So you can just go to pharmacy and they can prescribe Paxlovid under the FDA orders. So US has not done well. So I do not know how the numbers would look for US, but for the other countries, we have seen how this dominance pans out.
The other thing that's probably perhaps an even better, although it's not as strong theoretically, is what the frontline physicians are saying. You know, are they seeing people that are sicker? Are they seeing them go from coming in to being really sick or be on a respirator quicker or slower or change? And I guess I haven't heard people saying that things are worse in that field, but I haven't talked to very many. Have you had any feedback from folks?
No, so the only news I heard was somebody said that FLCCC, which, so I am associated with FLCCC for their medical content generation for long COVID, but they said that yesterday, FLCCC had some doctors who said that they're seeing more lower respiratory tract infections with BA.5. And that then gets tied into this Japanese study, which said that, hey, in vitro, the virus seems to be more infectious for the lower respiratory tract cells in vitro, plus it is more fusogenic, so it must be more pathogenic as well. But that is two doctors and their experience. And here is a study which is without the whole body. Numbers with the hospitalizations and deaths, which are in the larger numbers, for example, on our world in data, these are the numbers that can actually give us a better idea of what is happening.
Very good. Now I want to talk a little bit about long COVID and looking at some numbers from the UK because we have better data from that. And so the question is whether long COVID is a change in long COVID is simply that there's some people that are susceptible to long COVID, and that those people the population is getting depleted. And so is this really an add-on to COVID, or is it a separate, essentially a separate disease that's going on? And some of the people that get long COVID or get severe COVID or asymptomatic COVID get the long COVID. And so one of the questions is, are we going to, and if this is right, that there's depletion, then the increase in the UK of COVID will tend to change, and places like Australia and China and New Zealand that haven't had as many infections may see that their long COVID rates jump up with the Omicron versus not jumping up. And taking a look at the Zoe Health data, this is where we are right now, and drawing a line sort of approximating, it does not look like we've had, maybe we're having an inflection point right here where it's starting to come down a little bit. And if we look at the prior Omicron infection, you can see the rate went up faster, a little faster. And when we had the inflection point, we went up a fair amount. And we are essentially at the same point, or maybe even a little higher right now. And so if this is the same inflection point, one would expect that we go between 4.5 and 5 million cases in the UK for this new BA.4 and 5 infection. And again, they're the only folks that have this app talking about symptomatic cases, and these are just symptomatic. So the asymptomatic cases, you can add another 20, 30%, whatever the favorite number is for asymptomatic to symptomatic cases, and the folks that have a symptom but aren't reporting it for the COVID app. And you can see the prior cases for the prior one and the prior, that these were all less rapid. The first Omicron was more rapid, and now the BA.4 and 5 is more rapid than any of them except the first Omicron infection wave in the UK. So that's just looking at curves and looking where the curve changes. So any questions, concerns about that? If the U.S. isn't really reporting cases, then are we following the same trajectory as the UK or not? Appeared before that the UK had more cycles than we did of the various infections. So it may not be a good model, but if there's no test in the US, it may be the best that we have.
Cool.
Moving on, looking at the antibodies, you can see that essentially everyone in the UK has antibodies. The lowest to the 70 to 74 is 95%, and everybody else is higher than that. And the 80 and over are 99%, and the 75, 99%. And the 70 to 74 drop to 95. And then down to 65 and 60, and then it goes up again. And so it looks like everyone in the UK is getting exposed consistently to have the high antibodies rate. And these are the Office of National Statistics numbers that they have. And they show deaths slightly increasing. ICU infections are remaining low, but they're increasing. Hospital admissions are coming up significantly, and the percentage of people testing positive in the UK, again, is increasing. They're at 3 and a third percent. And take a closer look at the people reporting the long COVID. The next slide, I'll just blow that up. And it seems really weird to me. I mean, here's the curve, and the slope of increase has been essentially the same with these periods where it is flat. And they just added this last point. And without this last point, it looked more impressive with the upswing. But it looks like they're increasing the percentage, and this is the total, not the new people. This is the total estimated percentage of people living with self-reported long COVID. And for it to stay the same or decrease, you have to have the same or fewer new COVIDs versus the people that are getting cured or exiting out or dying on the other end of the COVID. And so we had a long period here, several weeks, where there was no increase. We had 2 increases, fairly level. And then we had 1, 2, 3, 4, 5, 6 weeks increase at the same rate. And now we have a week where it is essentially leveled off or dropped. It was 3.1 last month, and now it's 3. So it came down just a little bit, and it came down a little here. And this one was coming down. So it looks like we're getting a reoccurring pattern for whatever it is. And they have 13% at 1 month or longer saying that they have long COVID, 2.5% at 3 months, and more than 30% at 6 months of those that were hospitalized said they had long COVID. So those are the numbers that they had.
So that is the risk with more cases, which if we defined long COVID, to me, it seems like as concerning as somebody becoming severe, because long COVID is also causing huge issues. So if we take long COVID as a severe problem, then more cases will cause more number of long COVIDs.
Right, and this is coming down. If we go back and look at their incident rate here, we had this long period here where it was coming down, but the long COVID cases kept going up. And it had this increase now for a fair period of time, a month or so, and then the cases here are just starting to level off. So I don't know exactly what's going on here. But
could that be that the cases are really self-reported or tested, and there may be asymptomatic cases, or the cases that are not being reported at all, and they are though resulting in long COVID, and those long COVID are being reported?
It could well be. We've had a tremendous change in the number of reported cases, and our long COVID just keeps going up. And again, this increase going up is saying we're having essentially the same number of new people in the UK that are starting to report long COVID over those that are exiting out of long COVID. And it's not seeming to make any difference what the infection rate is. And that's why I was suggesting maybe this really can be better viewed as a separate disease. It may be caused by the same virus, but it may be a separate mechanism that's causing it, and the number of cases that are going up, maybe something different is happening with the folks getting the acute COVID versus the long COVID.
Interesting thought. Yes.
And I had someone that asked, was it yesterday, the day before, about the mortality, and John Campbell had something about that. But if we take a look at the mortality rate in the UK, this is not the same graph he had, but this goes back just to 1960, and you can see it's fairly level. And then starting about 85, we started having a decrease in the mortality and a fairly less steep decrease until 2010. Something happened at 2010. And we started having an increase, and then we hit the COVID. And we're going from about 11.5, 12 down to 8.75, and now we're back up to 9.25 or so before COVID came in. And so it would seem that if there was a call for the government to take a look, if I were looking at it, I would say, COVID's an interesting thing. It's going on. We need to know about that. But why has the deaths gone up since 2010? Was there something that happened medically in the UK at 2010 that caused this dramatic from a decrease to an increase? That's a tremendous shift. Well, maybe it happened worldwide. There's a worldwide number. 2010 doesn't look like anything significant happened. And they were at about 12 in 1980, and then they came down. And now, look, the worldwide rate is 7.8. In the UK, 9.25. Just due to a different age demographic? Is it due to the fact that there's better effective medical care in the world? In the last slide, sitting in the US, clearly we're not going to be as bad as the UK, right? Well, there's the US rate. We started at 9.5 rather than the 12 that the UK was. We were flat. In 1970, we came down. 1980, we were flat for 20 years. Then for 10 years, we came down. And then 2010, same thing. We started going up. Somebody might say, oh, it's where the healthcare law passed in the US. Well, that had no effect in the UK, and I don't think it would have an effect year one. So there's something else that's occurring, going up. Is this increased disease in the US? Is it the age? Is it the baby boomers starting to reach the age where they are starting to have more deaths and going forward? Is this just a reflection of demographics? Is it a reflection of poor diabetes and heart control? You notice that the US just barely got below 8 in 2010. Go back to the world. They got under 8 from 2008, and they've been below 8 the whole time, even with COVID. And the US spends more on healthcare than anybody else does. So one can wonder about the efficacy of what we're doing.
But clearly there is a overshoot at this time
Yeah.
within this era.
And the US has a much higher jump than the world and a much higher jump than the UK. Because we went from 8.75 to what? Over 10.25. So we went up 2 whole percentage point. Right. 3 whole percentage points. We go back, the UK went up the UK went up about 3 percentage points. And they went about 1.5 percentage points, and we went up about 3. And the world had a much smaller impact. And perhaps there's some reporting issues here, but seems like there's something here for people to learn.
Got it. Very interesting.
And if people are thinking, the world, we need to be sharing with the world the stuff we're doing and whatever. And we have folks that are spending a lot of money and effort to try to bring healthcare to the world. And it looks like we're getting a real benefit and we brought them to a better shape in terms of the crude reported death rate than either the UK or the US. And so if part of the world desire is to bring effective healthcare, we are apparently exporting the good stuff to the rest of the world. Or we haven't learned what they know and we haven't imported it here. I mean, I'm not saying that we're the only people that can have good healthcare, but whatever it was before, it has continued to improve. So something is happening worldwide that is not happening in the US or the UK.
John Snyder says, no, US all-cause mortality shot way up. Is it people dying from sequelae of COVID-19, or is it increased loads on hospitals plus a great resignation reducing staff?
Or is it people not getting the medication they would have otherwise gotten, not looking at the cancers or whatever? And some of the cancers are 4, 5, 2 years out, and so I would expect that if it's people missing their initial screening tests, we're going to see this rate being up for quite a while.
And there are theories as vaccine is doing it or the virus is doing it. I think there is going to be a mixture of a lot of reasons.
Certainly will be a lot of papers written.
That's true. That is true. So
that's what I had.
Excellent. So Paul, thank you very much. As usual, this is the best part of my week because when you are presenting, I am just sitting around having my cup of coffee or tea. Today it was tea. Jasmine tea.
I'm glad you get to drink your tea.
Yeah. So thank you very much for being here. Cool Beans, I'll see you on the chit chat side. If you would like to do some art and then do some neurogenesis, we'll do some art on that side. And I would see you in Cool Beans Cafe live in a few minutes. Paul, once again, thank you very much.
You're quite welcome, Over.